Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Carmen Fong. She's a colorectal surgeon and author of the new book, Constipation Nation, What to Know When You Can't Go. There's an excerpt from
Right.
that book on KevinMD, why your doctor wants to talk about poop, and it could save your life. Carmen, welcome back to the show.
Thank you so much for having me, Kevin. Always a pleasure.
All right, so let's talk about this KevinMD article that is based on your new book, why your doctor wants you to talk about poop, and it could save your life. Tell me what this article is about.
Yeah, so people ask me all the time, like, why did you go into this business? How come you would want to be a colorectal surgeon? And I always start by saying, I went into this because I wanted to cure cancer. Early stage colorectal cancer is curative with surgery, like stage 1 and stage 2. But as time went on, I kind of saw more and more anal rectal disease and found that patients just were very, very satisfied with having their, anal rectal problems treated. That these are frustrating problems that people don't want to talk about, and their physicians don't know how to handle. And so eventually I kind of just fell into this space where I mostly do anal rectal stuff and deal with a lot of constipation. And then eventually it became a book because I was talking about it so much that I started making these little pamphlets where I would hand them out to patients, and then my MAs started requesting them, and then residents and fellows started requesting them. And it kind of evolved into like this huge thing, like an actual book, because I wanted to, as a surgeon, I want to know everything. So I want to have answers for everything. And I was like, well, I'm just going to look into, what exactly type of fiber we should be eating, like how much water, how much fiber. Because while we were, generally taught, okay, somebody comes into the ER for hemorrhoids, well, tell them sitz bath, fiber, hydrocortisone, but like how much fiber, like how much water, what type of sitz bath. So that's where this stemmed from.
So tell me about removing that stigma about talking about bowel health. What are some of the things that you do to make patients feel more comfortable talking about topics that are to them considered taboo? So how do
Mhm.
you make patients feel more comfortable and destigmatize the topic of bowel health?
Yeah, I think that most of the thing is actually just talking about it more, in general, like having it out in the open. I found that patients generally fall into two groups. One is they'll be like, I really want to talk about my bowel health,
Yeah.
and then the other group will be like, please don't ever mention it, to the point of, I don't want you to talk about it. I don't want you to look at it, whatever. Um, and I think that maybe the younger generation is more starting to do it and like more involved with their bodies, like in tune with everything that's going on, very into wellness and like having overall preventative health. I think my personality has a lot to do with it, honestly, because I feel like people who become colorectal surgeons tend to have a little bit of a sense of self-deprecating humor, and where I go in and try to make the patient, like, immediately comfortable. So, be like, well, I know you're here, this sucks, but we're going to try to make it as good as possible. The other thing is really, really talking through everything, where I say, I'm going to tell you everything I'm doing, in terms of this procedure. It's a sensitive area, but I will tell you exactly where my hands are going to go, what's happening now, so you're not like surprised when
Yeah.
something happens. And then lastly, again, education is like such a big part of it. Like, part of the reason why I do the book and why I do TikToks is that, people don't know that, over wiping causes itching, or, people don't know that there are two types of hemorrhoids. So, really taking the time to go through that, I think, makes people comfortable and trust you and have, that you're on their side.
So tell me some of the most common questions you receive from patients about their bowel health.
Ugh. Okay. So I would say the number one thing is if pain is a problem. So, hemorrhoids bleed and they prolapse and they swell and they itch, but I would even say that people don't often come in for hemorrhoids.
Mhm.
Even though I work at Hemorrhoid Centers of America, they come in for fissures, because by the time it's painful, they're like, okay, something is wrong. Like,
Yeah.
I have to go in. And then so the pain is usually not a sign of cancer, right? So people are always being like, well, I want to make sure it's not cancer. Anal cancer, while it does hurt, it's usually not like the first thing. You're going to have itching, you're going to have a lump there, you're going to have bleeding before you have like terrible severe pain. Pain tends to be an external thrombosed hemorrhoid or an anal fissure. So either a cut in the butt, or you're feeling a lump the size of a blueberry. Differentiating between all the anorectal diseases is one of the first things people would be like, I think it's a hemorrhoid, but it could actually be X and X and X.
Mhm.
The next most common one is probably itching. I would say, what causes like itching around the anal area. And, while this can be super multifactorial, the main things I would say are over wiping, wiping with preparation H or like witch hazel wipes, like some sort of medicated wipe when you don't need to be doing that on the outside. And then, obviously hemorrhoids in and of themselves can cause kind of this veiny, wormy, itchy feeling when they're swollen. And that's where we know, after an examination that you have to treat them.
So, in your article, you talk about some of the cultural influences and gender dynamics as it relates to people expressing
Hmm.
their bowel health. So, talk more about
Hmm.
each of those factors.
Yeah. So I have to say, I think I also talk in the article about where I think my interest in poop maybe stemmed from, more like my no fear of poop is from my very, very practical Chinese grandmother who, it's like a bodily function, it has to happen. And so there's really no way of going around it. And at one point in my life when I was a teenager, we went to her house and, I remember going to the bathroom and I was like, oh my gosh, there's a little poop in the toilet. And she just actually went in there and came out and scooped the poop up and was like, flush it down the toilet. And she said in Chinese, Stigma, which is, it's just shit, it's just
Yeah.
poop, literally, nothing to be afraid of. And so just basically from that, I'm like, well, it's true. It's just poop. It's always just poop. And we have to do it. We have to take care of it. So culturally, I think that there's definitely going to be differences, in how people are raised, like what your attitude towards, bowel habits is. There's also this huge culture, though, in our generation of poop shaming. So, uh, this is why I wrote a book because I could go on about this forever.
Sure.
So, when people are potty trained, they're taught that okay, you can only go at certain times, you can only go in certain places, and that anything related to poop or bodily functions is gross. So as soon as you have a baby and you're like, oh, ew, stinky diaper, they're already thinking, wow, this is associated with shame. This is
Hmm.
associated with you don't want to poop. It actually does lead to some childhood constipation where kids will be like, hey, I don't want to be ewed. Like, I don't want to say people to say that I'm stinky. So they'll actually hold in their poop. There's actually different reasons for it, but that's one of the reasons. And then after holding in poop for a period of time, you start to get a little proctitis, like things start to hurt. And then when it starts to hurt to poop, then you really don't want to poop. And then it becomes a vicious cycle in children that way. But stems from like our attitudes towards poop and potty training. And then, and we talk about there was a New York Times article which I talk about in the book, which was really, really eye-opening that, women will go to certain, extremes to avoid pooping in public,
Hmm.
or pooping at work. They'll go to a different building, they sell, now they sell things where it's poopery where you spray and so people don't have to smell it. In Japan they actually have, amazingly bidets everywhere, but the bidets now have like music or white noise fans so that if someone's in public and you have to go, nobody's hearing it next to you.
Hmm.
So it's on the one hand it's great that they have bidets, but on the other hand we're still contributing to, well, it's not normal to poop and so therefore you have to cover up the smells and the sounds and the sensations of going. And then lastly, there was another article where they actually talk about normalization of bodily functions. And it's actually way more common in women and, men who have sex with men, or they actually said, homosexual men versus homosexual women and heterosexual men have less problem pooping in public just because those are like societal norms. It's you have to be a certain way, you have to be
Hmm.
clean, you have to be smelling good. So all of those things.
So, of course, your article is based from your book, Constipation Nation: What to Know When You Can't Go. You obviously wrote a book about this whole topic. So, tell me some of the big take home messages you want readers to come away with after reading your book.
Yeah. So, people always ask me like, okay, so how much fiber do I eat? So the
Yeah.
general rule of thumb is 25 to 35 grams of fiber, a little bit less if you're like a smaller woman, a little bit more if you're, a bigger guy. And then it should be both soluble and insoluble fiber. And a good example is an apple. And so right now I'm trying to eat an apple a day just, to see what happens. But apples have really good source of both soluble and insoluble fiber. So the pectin on the inside, the flesh, is the soluble stuff that turns into a gel. but the skin is insoluble. And so that's the roughage that will kind of stimulate bowel movements, but that gel is also necessary to kind of bind everything and move it through. That same soluble fiber is found in cereals, but I also kind of caution against using cereal as your sole source of fiber because that tends to be mostly soluble. Right, so you need to have some fruits and vegetables and roughage in there. So again, 25, 35 grams, soluble and insoluble fiber. And then water daily should be about 2 to 3 liters. Most people don't get enough water, like 100%. I know I don't most days unless I carry a big water jug with me because you don't want to be peeing all day when you're working. But the water is important because fiber without water just sits like a concrete in your colon and it turns into a gel and doesn't go anywhere. So it has to be washed through. Again, if you're more active, if you're pregnant, if you're in a hot climate, it should be more really towards the 3 liters of water, which is, 3 liters like this, as opposed to the 2 liters. There's a whole chapter in there about pregnancy and constipation, which is a super common thing. Like I see it postpartum, people had constipation during pregnancy and they have hemorrhoids afterwards. I won't go into that in depth here because that's again the whole chapter, but because of the physiologic changes, because of the hormones, and because of the anatomy, you can actually have, pretty bad constipation during pregnancy. You treat it the same way though, with fiber, water, and then laxatives if needed. An osmotic laxative like Miralax is best. It's safe, it's not addictive. But the other things that are addictive are, like Dulcolax or
Hmm.
Senna. Those are stimulant laxatives, which it's not like 6 months. It's like over years and years of use. Your colon might become used to it and kind of need it to function. So we did fiber, we did water. So moderate activity is important. So, they recommend 30 minutes 3 times a week. I think that moderate activity is fine. Some people will be like, oh, I exercise so much, but that actually, it makes my pooping worse. There's a couple of reasons for this. When you exercise really hard, you actually can, you get dehydrated, first of all. But the second thing is that you're actually simulating like a sort of cortisol stress response
Hmm.
where you're doing fight or flight, and your body in fight or flight mode will not digest, right? Because the opposite is rest and digest. So you actually can't be working out too hard expecting your bowels to function. But moderate activity is important and is required for your colon to be stimulated, for gravity to move everything through. So those are the three main things. The things that I think are, sometimes a little bit controversial will be like probiotics. But from my research, I found that there are good strains of probiotics to have. You need a good mix of probiotics and you need a good, number of probiotics. And so while a lot of the research shows that probiotics don't work, on their own or one specific strain doesn't do a specific thing, I found that certain strains like Bifidobacterium or Lactobacillus, having that combination for most people will affect the frequency of bowel movements. It doesn't affect the consistency, but it affects the frequency.
So let me give you some common primary care scenarios and ask you
Yeah.
how you would approach this. So I typically see an elderly patient, perhaps in her
Hmm.
70s or 80s, with worsening constipation. Tell
Yeah.
me what kind of dietary changes or suggestions that you will make, and at what point would you consider laxatives in a patient that doesn't have, say, any other pre-existing medical conditions or medications that may be leading to this?
Right. Yeah. And so, the general evaluation is always like a trial of, I would say, fiber first, do a good dietary and stool intake, see exactly how much fiber and water they're taking a day, how many bowel movements they're really having a day. And then the nature of the bowel movements is important. So while most people will say, oh, they're constipated, I think the definition can vary. So it's, are they going every day? Are they, going every day but having a hard stool? Are they going every day but feeling incomplete after they go? Because all of those will slightly change the management somewhat. And then obviously, and we're not going there yet, but if all of our interventions fail, then, I will have them do testing for, pelvic floor dysfunction, which, I always explain it to patients like if the door is closed and you're trying to push against a closed door, it's not going to work, right? Or if your door is, completely open, like in older individuals, but you compensate by trying to keep the door closed, you can't go. So things like MRI decocography or
Mhm.
anal manometry or a 6-month study. But to go back to the elderly patient, so trial of fiber and water, add a probiotic, and then this is actually like only barely touched upon in my book because a lot of the research came after it came. I wrote it is magnesium. So throwing magnesium at them, like even 400 milligrams a day, actually significantly can change like your bowel frequency and consistency. And then after all of that, I usually do it for a week or two. And most people, about 85 to 89% of the time, statistically, will have some change in their bowel habits with just behavioral and lifestyle modifications. And if that still doesn't work, then I try a Miralax cycle, and either a Miralax cycle or a Miralax trial. So you can try it, every single day, a capful a day for a day or for a week or so. Or sometimes, depending on if they're like, oh, it's like an occasional hard stool, I'll do a cycle where it's 3 days on and 3 days off, so that, most people poop in between 1 and 3 days, right? So people will say, if I take it every day, I end up having diarrhea, on the third day. So you're actually just tailoring it so that on their third bowel movement, they're still going consistently rather than having diarrhea 3 days later. The important thing is like the instructions though for doing Miralax. For example, it's, take a cupful of Miralax, but then drink a glass of water after it,
Hmm.
drink 2 glasses of water after it. I usually tell people try not to mix it into your coffee or juice, especially coffee. It's like negative water intake. You're
Hmm.
putting in caffeine and dehydration with it. So try to mix it with a glass of water and then, 2 glasses of water afterward to wash it through. And it does work.
And when you suggest fiber, you mentioned apples earlier. Uh,
Hmm.
Proverbially, people recommend things like prune juice. And
Yep.
then, what's your thoughts about things like Metamucil over the counter for fiber?
Yeah. Yeah. So Metamucil is great. Metamucil, Benefiber, Citrusel, Psyllium Husk, like all of those things are versions of similar things. I think Benefiber is the one that's wheat dextran versus Metamucil is actual Psyllium Husk. So a little bit of difference there. Metamucil is, Psyllium Husk is shown to be the best fiber supplementation that you can take. So even just doing like ground psyllium husk on your cereal or on your salad or something will work. But again, same thing with, Metamucil and Miralax. You want to take it in water, wash it down with 2 glasses of water afterwards. People will be like, hey, I had a glass of Metamucil, I'm still not going. How come? Having a glass of like Metamucil in isolation, if the rest of the day you eat chicken wings and French fries, is probably not going to help that much. So I would say do a fiber supplement. There's actually like just so many forms of fiber now that I think that people can get a little bit overwhelmed. And people who don't like the fiber, powder though, because like you mix it and it's a gel and it's gross. It comes in capsules, it comes in pills, and most recently I've actually been recommending gummies because people will take
Mhm.
gummies. Like they're like
Sure.
very compliant with taking a gummy a day, you know?
So let me give another typical primary care scenario.
Hmm.
Perhaps a younger patient that you suspect with irritable bowel that has constipation
Hmm.
symptoms alternating with diarrhea. So in
Yep.
those cases, how would you approach something like that?
Yep. So again, it's almost like a similar approach, but the bowel diarrhea is more important here because it's like, are you getting constipation and then diarrhea the next day? Or are you like, diarrhea predominant? A little education here does help though. So fiber, whereas it helps with, constipation, also helps with diarrhea, right?
Mm.
So because it's a bulk forming, substance, if it's too hard, it makes it a little softer. And if it's too soft, it makes it a little
Mm.
harder. So consistent fiber intake, and for these ones, definitely start with a fiber supplement and a probiotic. In IBS patients, they'll have come in and I've been on Bentyl, like I've been on blah blah blah, amitriptyline, all these things that do work with the hypersensitivity of the bowels. But I find that fiber normalizes their bowels, and then the probiotic again affects the regularity, the frequency. The one other thing that sometimes helps with IBS patients, especially when there is a lot of bloating involved, is a digestive enzyme. So not creon or anything like that, but digestive enzymes like BINO or lactate, just
Mhm.
to see if it's really these like higher carbohydrate foods that are causing the bloating, or dairy products.
And in terms of the probiotic, the stuff that you find over the counter, like a
Mhm.
Culturel, that has been shown to be effective.
Uh, yeah, so cultural and like align, like those have like been clinically proven to be effective. But I find that sometimes people will take a certain probiotic and it doesn't work for them. And we don't have research into this yet, but I think that we're going to see this in the future that certain strains work better for certain people, because of your previous microbiome. And so I've told people that you don't need to go with the name brand. You can actually just I take the Costco brand. Take the Costco brand. It has 1 billion CFUs. It has a good blend of different bifidobacterium and lactobacillus, including rhamnosus and casei. And And that should be it. Like you can take and you can switch and see if there's a different one that works better for you. They've actually come out with a bunch of new ones these days where, because part of the problem is that probiotic capsules get digested in the stomach and don't make it to the colon. So there's a couple different formulations I've seen where they have a special capsule or like a special enzyme where it doesn't get digested before it gets into the stomach. I haven't seen research that works like better yet, but I think that's coming.
We're talking to Carmen Fong. She's a colorectal surgeon. She's the author of the new book, Constipation Nation: What to Know When You Can't Go. Carmen, let's end with some take-home messages that you want to leave with the KevinMD audience.
Oh my gosh. I could talk about this all day. So, I think the one major thing is, my one bowel commandment that I talk about in the book is go when you have to and don't go when you don't. And that will actually prevent, 99% of the problems. So a lot of people will be like, hey, before I rush out for work in the morning, I have to make myself go to the bathroom and do whatever it takes, squeeze, strain, whatever, you're gonna, squeeze some hemorrhoids out. And then on the other hand, once you're at work, you're like, I'm not going to go to the bathroom. I'm
Mhm.
going to try to hold it in as much as possible. And you hold it, hold it, hold it. And eventually over time, it turns into anal spasm and gives yourself a fissure. Pooping is normal. Everybody should go. And I think that, if, like I said, yeah, go when you have to and don't go when you don't. That's it.
Carmen, as always, thank you so much for sharing your perspective and insight. Thanks again for coming back on the show.
Thanks.